This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alera, Research Fellow. Today we're looking at a fascinating new study from the Scandinavian Journal of Trauma, Resuscitation and Emergency Medicine titled Decompressive Craniectomy in Traumatic Brain Injury, Insights from a 15-year multicenter cohort in Sweden, published in 2026.
This is a timely discussion, Ilara. Decompressive craniectomy, or DC, remains one of the most debated last resort treatments in our field. For our residents listening, we know DC is indicated for severe traumatic brain injury with refractory intracranial hypertension. But the evidence base has been, well, let's call it complicated since the landmark RCTs came out.
Exactly. We have the DCR trial, which suggested functional outcomes were inferior with early secondary DC, and then Rescue ICP, which showed reduced mortality but increased rates of severe disability. This Swedish study provides a real-world look at how these trials actually influenced practice over a 15-year period, from 2008 to 2022.
It's a multi-center effort, 4 Swedish neurosurgical centers, covering nearly 300 patients. What was the baseline for this cohort, Ilara? Who are we actually operating on in Sweden?
The demographics were quite classic for TBI, a median age of 37 and predominantly male, about 76%. These were very severely injured patients. The median motor Glasgow Coma Scale, or GCSM, was less than 6. Interestingly, 48% of the cohort presented with unreactive pupils, which usually signals a very grim prognosis.
That's a high percentage of unreactive pupils. Now, looking at the surgical trends over those 15 years, did the publication of DCRA and Rescue ICP actually change the way Swedish neurosurgeons operate?
Surprisingly, the authors found that these landmark RCTs appeared to have had limited influence on Swedish DC practice. The annual DC rate remained remarkably stable, with only a modest decline from 3.6 to 3.2 per million inhabitants. Even more interesting is that the proportion of primary versus secondary DC and the timing of the surgery remained largely unchanged over the 15-year period.
That is a significant finding. It suggests that clinical intuition and local protocols might be outcompeting the RCT data in the real-world setting. But they did see some changes in technique, right?
Yes, they noted a decrease in bifrontal DCs. However, they observed significant regional differences across the 4 centers regarding timing, indications, and specific techniques used. It seems that where you are in Sweden might influence the type of decompression you receive.
Let's talk about the immediate surgical effects. We do these surgeries to snap the brain back, so to speak, to alleviate that mass effect. What did the radiological data show?
The radiological improvement post-DC was statistically significant, with a p-value of less than 0.001. They measured this by looking at the midline shift and the status of the basal cisterns. Essentially, the surgery is doing what it's supposed to do anatomically. It creates space and relieves the physical compression.
But it's not without cost. DC is a surgical trade-off. You trade intracranial pressure for the risks of an open skull. What were the complication rates in this 15-year cohort?
They were consistent with what we see in practice. Reoperation for hemorrhage occurred in 10% of cases. Then you have the 5% club. About 5% required complementary decompression, 5% suffered from surgical site infections, and about 5% developed subdural hygromas. And of course, we can't forget that these patients all eventually require a cranioplasty, which brings its own set of risks like bone flap resorption and further infection.
Let's dive into the outcomes. This is the heart of the debate, survival versus meaningful recovery. What did the 6-month Glasgow Outcome Scale, or GOES, look like for these 299 patients?
At the 6-month mark, 60% of patients had what is classified as an unfavorable outcome. However, only 11% were deceased.
Wait, let's pause there for our residents. 11% mortality in a cohort where nearly half had unreactive pupils and a GCSM under 6, that mortality rate is actually quite low compared to some of the earlier literature.
Precisely. The authors pointed out that these real-world outcomes were actually more favorable than those reported in recent RCTs and other studies of acute brain injury. It suggests that in a modern neurointensive care setting, we are saving more lives with DC, even if the functional recovery remains a steep climb for many.
Did the study identify specific predictors that help us prognosticate who will do poorly despite the decompression?
Yes, they identified several independent predictors of an unfavorable outcome. Higher age was a major one, along with a lower initial GCS. Pre-existing comorbidities and impaired pupillary reactivity were also strong indicators. Radiologically, the presence of obliterated basal cisterns was a significant predictor of a poor result.
So, if you have an older patient with multiple comorbidities and obliterated cisterns on the CT, the DC might save their life, but the 6-month functional outlook is statistically quite poor.
Exactly. And the study emphasizes that DC should only be considered after exhausting less invasive options like osmotherapy with mannitol or hypertonic saline and sedation. But the catch is not to wait so long that you allow irreversible secondary brain injury to develop. It's that golden window that remains so difficult to define.
The authors use a very specific phrase in their conclusion about Swedish practice. They say it remains variable across centers. Ilara, as a researcher, why do you think we see such variability despite having international guidelines?
I think it goes back to the limited influence of the RCTs they mentioned, because DCRA and Rescue ICP provided somewhat conflicting messages, one saying don't do it too early and the other saying it saves lives but at a cost. Surgeons are often left relying on institutional experience. This study shows that despite the push for standardized evidence-based medicine, the decision to perform a DC remains highly complex and individualized.
It's also worth noting the stability of the procedure. For a last resort treatment, a rate of 3.6 to 3.2 per million inhabitants over 15 years shows that DC has a fixed, albeit small, place in our neurosurgical armamentarium. It isn't going away.
And for the medical students listening, it's important to remember the secondary effects mentioned in the paper. The disturbances in cerebral spinal fluid circulation post-DC are a major factor in recovery, which is why we see those 5% rates of hygromas.
Let's summarize the take-home points for our listeners. First, DC in Sweden is performed on young, severely injured patients with a very low mortality rate of 11%, which is quite impressive. Second, the surgery effectively improves mass effect radiologically. Third, age, GCS, and the state of the basal cisterns are your best tools for outcome prediction.
And finally, that the landmark RCTs haven't shifted the practice as much as one might expect. The real-world application of DC in Sweden has remained steady, with outcomes that actually exceed those found in controlled trials.
It really highlights the importance of neuro-intensive care alongside the surgery. You can't just take the bone off and walk away. It's the 15-year evolution of the entire care chain that likely contributes to that 11% mortality figure.
Definitely. It's a fascinating look at how a specific country manages one of the most high-stakes procedures in trauma.
Well, that's all the time we have for today's episode. Thank you, Dr. Ilara, for breaking down this multi-center cohort study.
My pleasure. We'll link the full study in the show notes for those who want to look at the regional data and the supplementary materials.
Until next time, keep learning and stay sharp. I'm Dr. Aris.
And I'm Dr. Ilara. This is the Neurosurgery Hub podcast.